From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to this JAMA Clinical Review podcast. I'm Maria McDermott, Deputy Editor of JAMA, and I'm here today with Dr. Martin Reincke, who is Chairman of Medicine at LMU Hospital in Munich, and also with Dr. Maria Fleseriu, who is Professor of Medicine, Neurological Surgery, and Pituitary Center of Oregon Health and Science University, Portland, Oregon. And today we'll be discussing the narrative review published in JAMA on the diagnosis and treatment of Cushing Syndrome. Welcome, Dr. Reincke and Dr. Fleseriu.
Thank you for having us.
Good morning.
So let's start with a question about what is Cushing syndrome and when should it be considered as a possible diagnosis?
We should think about patients having Cushing syndrome when they have a corollary of symptoms from abnormal weight gain, women with irregular periods, extra hair, we call it also hirsutism, and symptoms as depression, and also a lot of clinical features, including hypertension, diabetes. It's not just one in itself. Patients should have more than one symptom to think about screening for Cushing's, and then becomes very complicated how to do it.
And what are the most common causes of Cushing syndrome?
The most frequent cause of Cushing syndrome is actually exogenous glucocorticoid use with higher doses of glucocorticoids. So this is a very frequent cause of Cushing syndrome. Endogenous Cushing syndrome is much more rare, 2 to 8 cases per million per year. And there are small tumors in the pituitary, in the adrenal, or sometimes ectopically somewhere in the lung, which can cause Cushing syndrome.
And your article talks about Cushing disease and Cushing syndrome, and I wondered if you could distinguish between those two.
Cushing syndrome represents everything that includes excess cortisol. So it's exogenous Cushing's, as Dr. Reincke said earlier, that's due to steroids used orally or even intra-articular injections, for example, or intranasal inhalers with steroids. If they are used too much, can induce exogenous Cushing's. The endogenous part, so meaning secretion from the body of either corticotropin or cortisol, this is the endogenous Cushing syndrome. The Cushing's disease part of it is just the name of the Cushing's caused by a pituitary tumor. So this is the part that is actually the largest one, because in addition to the exogenous steroids is the second cause and the first one for endogenous cortisol secretion, and it's also called Cushing's disease. But the difference is just what's causing it. But every other causes of Cushing's, it's called Cushing syndrome.
And so if we consider only the endogenous causes of Cushing syndrome, you indicated that Cushing disease was the most common cause. What proportion of Cushing syndrome does Cushing disease make up if we consider only those with endogenous cortisol production?
This is 2/3 of all the cases of endogenous Cushing syndrome, between 60 and 70%.
And then the rest of causes of endogenous Cushing syndrome, what are the most common after Cushing disease?
After that, we have adrenal Cushing's. So this is an unilateral or bilateral tumor, adenoma, or hyperplasia that is between 20 and 30%. And then we have the remaining 8 to 10%, which is the ectopic Cushing syndrome, when the origin is neither in the pituitary nor in the adrenal. Normally it's caused by neuroendocrine tumors, small tumors, mostly above the diaphragm, for example, in the lung or in the thyroid.
But let's not forget that these numbers are changing constantly. One, Cushing's is clearly underdiagnosed, and also with more imaging, we find different types of Cushing's being more prevalent than others. So in a few years, the numbers could change significantly. So everybody should be on the look for diagnosis of Cushing's, and then further localization is very important because it's not always as it seems. Patients can have a pituitary incidentaloma, for example, in the pituitary, but doesn't mean that that's the cause of Cushing. So that's very important.
Mm-hmm. How is the diagnosis of Cushing syndrome made?
The first step is always high degree of clinical suspicion, because the tests are very good, but they are not perfect. Therefore, we have to select those patients who have, as Maria was saying, the number of symptoms which are indicating that this is endogenous Cushing syndrome. And if this is the case, so if we have an increased pre-test probability, so to say, then we are using screening tests, and we have 3 screening tests which we are using there to diagnose Cushing syndrome.
Can you talk about those screening tests a bit, please?
We have 3 screening tests that we're using in general, and it differs between endocrinologists and, of course, between countries. The one that we use the most in US and are recommended by guidelines are the late-night salivary cortisol and the urinary free cortisol done in 24 hours. And then also, we're using the overnight dexamethasone test with 1 milligram taken at 11 p.m. and then the patient goes to the lab the next day between 8 and 9 a.m. These are in general recommendations. We need more than 1, usually 2 or 3, both for urinary free cortisol and for late-night salivary cortisol due to the variability in between samples. And the only time when we recommend to do just the overnight dexamethasone test as a first-line screening test is for patients that have adrenal adenomas. For them, because we're looking for more autonomous cortisol secretion, that's the initial test. Otherwise, a combination of 1 or 2 tests, and some of them done more than once. But everything, and I wanted to point out what Dr. Reincke said earlier, it's important to have high clinical suspicion. It's very important not to miss cases, but it's also important not to have false positive tests. So high clinical suspicion, if the results are normal, I just told you several screen tests, and you have high clinical suspicion, we still repeat the testing later because patients could still have Cushing's. If they are all normal and the clinical suspicion is low, then we stop testing. And then furthermore, these tests have to be confirmed. So this was just screening. Unless it's florid Cushing's that we call it when patients have so many clinical features like the textbook, we do confirmatory testing at least 1 just to make sure the patients have Cushing's before we look where it's coming from. That sometimes includes several tests and imaging, and we want to make sure.
Great. So there are 3 tests as you summarized, and you typically start with 1, but then you'll confirm. And you mentioned that the dexamethasone suppression test you reserve for people with adrenal adenomas in general. So I'm just curious, which of the other 2 do you typically start with in your practices?
In my practice, I do late-night salivary cortisol, at least 2. It's easier for the patient. They do before they go to bed. And then I do another at least 2 urinary free cortisol. Keep in mind that our practices are more focused on pituitary, so most of the patients that are coming to us, we have high clinical suspicion, so we're almost rushing towards a diagnosis. For somebody in a general practice or in a primary care practice, I would recommend starting with 2 saliva cortisol and maybe a urine. And then the overnight dexamethasone test, it's sometimes easier to be done in more rural area where the access to late-night salivary cortisol is not as easy, but there are some caveats that are very important. As we said earlier, the Cushing's disease is predominantly in women. So if these women are on oral contraceptive, the estrogen in oral contraceptives, it's actually increasing the binding protein, so the cortisol could look higher than it is. Unless this is noted before and either stopped or the dexamethasone level is checked and the cortisol has to be rechecked if it's a positive test, could give a diagnosis of Cushing's that's not real. So this is why we prefer to use it as a secondary test, plus it has false positives and false negatives.
Yes, Dr. Fleseriu very well pointed out. I believe that this is the reason why we are using 2 different tests, because each test has some limitations and some strengths, and in combination, they work better.
Now, who should be evaluated for Cushing syndrome? Like in the primary care office, when should a primary care clinician think about Cushing syndrome for someone not on exogenous steroids?
So there are more or less 4 categories where you should really look for Cushing syndrome. One is the presentation of abnormal symptoms are typical, for example, for age. Somebody who is well below the 50 years of age and has, for example, osteoporotic fractures or hypertension at young age. Then we have a second category, which is a combination of several unusual features. Recent weight gain, the increase in hair, as Dr. Fleseriu was pointing out, in females, this increase in hair on the body, hypertension, the metabolic syndrome, infections, osteoporosis, but also hypertension, skin changes like purple stria. So it's a combination of different symptoms. This is raising the suspicion for Cushing syndrome. Number 3 is adrenal incidentaloma or incidentaloma of pituitary and adrenal in general. And then very specific for the pediatric community in children, growth arrest, and at the same time increase in body weight.
So let's say you've got back your 24-hour urine, your salivary test, or your dexamethasone suppression test, and you have diagnosed Cushing syndrome. What imaging, if any, would you perform at that point?
That's a very interesting question, because once we have a clinical suspicion and we have these tests, I usually do another confirmatory testing, either the small pressing test. We used to do dexamethasone CRH test, but CRH is not available anywhere in the world right now. If the patient has all the clinical features Dr. Reincke described earlier, then we skip the confirmatory testing and we look for the cause of the Cushing's. Now, before we move to imaging, we like to do an ACTH, corticotropin value, because that's helping. If it's really low, it tells us that we should go and do imaging at the adrenal. If it's over the normal range, then we know that we should look in the pituitary, and then we'll look in other sources too. But pituitary, it's most likely, especially if it's a younger woman. If it's somewhere in between, then it's the harder part. We have to decide, and usually we do another value of ACTH in the morning just to see. And I want to point out that the ACTH type of assay is very important. So some labs are less reliable than others. So this also has been reported and published that sometimes the imaging is done in the wrong area because of these assays. But in a good lab with a good ACTH assay, if it's low, then we do CT of the adrenals, because the likelihood of being either unilateral adrenal adenoma or bilateral or other extremely rare disease, it's very high. And if the ACTH is over 20, then first thing we do a pituitary MRI. Now, if the pituitary MRI shows a small, tiny tumor, that's where the problem comes, because the likelihood of having a small pituitary tumor, an incidentaloma, with a new type of pituitary MRIs that are so good is very high. So 1 in 5 people can have it. So we don't know if you have that's the cause of Cushing's disease. What we have to do in patients that have smaller tumors, if it's a larger tumor, then we're done. Cushing's was confirmed, the patient has a larger pituitary tumor, then we're done. That's the cause of it, and the patient has to go to surgery. If the tumor in the pituitary is tiny, then we have to do additional testing. And in US, we do petrosal sinus sampling, and this is a very good test. Nothing is perfect, but this is a very good test to say, is the excess ACTH, because we already determined that the ACTH was over normal, is this coming from the pituitary tumor, or it's from somewhere else in the body, either lung or other, but it's usually lung, pancreas, and sometimes in the neck, and a few other rare cases that are reported everywhere in the body.
So if your pituitary image doesn't show a cause, what do you image next exactly?
The next step would be then to make sure, because we may have then an ectopic tumor somewhere else in the body. So you would do, as a first step, generally a whole body CT scan, looking for a very small and tiny nodule, for example, in the lung, or as Dr. Fleseriu pointed out, in the pancreas, in the thyroid, or somewhere else. So it could be every origin or every location where neuroendocrine tumors can be located. So that would be the first step to exclude or pinpoint an ectopic cause of Cushing syndrome. And of course, the petrosal sinus sampling is an essential step, not only to confirm that it's Cushing, but also to confirm that it is ectopic, to be honest. Because if there's no gradient from the pituitary in ACTH to the periphery, then we know that this must be an ectopic tumor somewhere in the body.
How about if you could please summarize the approach to management of Cushing syndrome once the diagnosis has been made?
So the management is very complex because it differs based on the cause. So for adrenal tumors, it's relatively easy. If it's one adrenal adenoma and that's the cause of Cushing's, then taking that adrenal out will cure the Cushing's, but there will become other problems. Secondary adrenal insufficiency is sometimes prolonged. But for pituitary tumors, the first line treatment, especially in US and in most other countries, is pituitary surgery in a specialized center. The cure rates between centers differ based on expertise. So this has been established all across the world. And even in the best surgeons, the cure rate is about 80% for smaller tumors and much less for larger tumors. And on top of that, about 30% of cases will actually recur. So it's very important to follow these patients, especially with Cushing's disease, long term. I had patients that recurred 20 years later, but they are reported some that are recurring even later. So once a patient has Cushing's, they have to be followed throughout their life. If the surgery fails or the disease recurs, we usually use medication, and we have several medications available right now in US and approved by FDA. And also sometimes patients need radiation therapy and then medication just as a bridge that depends on type of tumor, of clinical symptoms. And then if the Cushing's is very severe and not responsive to medications, or sometimes in women that desire pregnancy, then we recommend bilateral adrenalectomy. Taking the adrenals out again cures the Cushing's, but then there are other issues potentially related to that, including permanent adrenal insufficiency, and also the pituitary tumor can continue to grow and brings another disease that we used to call Nelson syndrome, and it's called now corticotroph tumor progression. And for ectopic,
We use, again, a personalized approach because these are semi-malignant or malignant tumors of different grade. And therefore, the first thing is always to remove the tumor if possible, or to do at least debulking surgery. And then we use additional approaches that includes radiation, it includes medication, static therapy, drugs which block the cortisol, because the high cortisol levels is very florid. Cushing syndrome is threatening the patient and the life of the patient. And then also chemotherapy, if it's a classical malignant neuroendocrine tumor, this is oncologic treatment.
What I wanted to point out for all the causes of Cushing's is very important not just to treat the cause of the disease. Yes, there are tumors. They are very important to treat. The cortisol in itself, it's very important either to treat or to block the receptor. But what's important also for all physicians involved in the care of patients with Cushing syndrome are the treatment of comorbidities. So the hypertension, the diabetes, the hypercoagulability with pulmonary embolism, the fractures, all these have to be treated in parallel, and also doses have to be changed. So we're sending patients and discuss in our multidisciplinary clinic, and then we involve the primary cares because the doses of hypertension have to be continuously decreased, for example, in diabetes medications when we treat the Cushing's. And then if the disease recurs, the doses change back. And then we know that the bone density actually decreases the first year after cure, and then it's increasing. And there are a lot of other subtleties. So perfect communication between all the physicians involved in the care team is essential for these patients with rare disorders.
Great. Thanks for that really useful summary. And thank you so much for such a wonderful and clear overview of the diagnosis and treatment of Cushing syndrome. Are there any final comments that you would like to make?
For the general practitioner, I think it's very important to keep the eyes open and to watch out for Cushing syndrome.
And I would like to point out that we're doing so much better than before, even 10 years ago. So the first medications for Cushing's were approved in US starting in 2012. So all of these are recent. We have advances in surgery, we have advances in imaging. So I think we're doing a better job overall looking at all the complications and the treatment of patients. We're not where we want to be. The morbidity and mortality of patients with Cushing's is increased compared with normal population even after remission. So we have way to go. The quality of life of patients with Cushing's does not return to normal, so we have way to go there. And we are starting to incorporate, and we did several studies, patient-reported outcomes in all the clinical trials, but also to look at the differences between patients. And we just have to move from, this is the first treatment, this is the best screening test. We should look at personalized, both screening based on symptoms and comorbidities, but also individualized management for each patient, and to incorporate the patient-reported outcomes in everything we do.
I've been speaking today with Dr. Martin Reincke and Dr. Maria Fleseriu about their JAMA review on Cushing syndrome. Thank you very much.
Great. Thank you so much for increasing awareness on Cushing syndrome. It was a pleasure. Thank you.
Thank you very much.
This is Mary McDermott, Deputy Editor of JAMA. This episode was produced by Shelley Steffens at the JAMA Network. For more of our podcasts, please visit us at jamanetworkaudio.com. You can subscribe and listen wherever you get your podcasts. Thanks for listening.